What if I told you that a fleeting feeling of stress or anxiety could actually compel you to do something that literally rewrites the cellular structure of your own skin?
Right. I mean, we usually think of our bodies as these rigid,
Hmm.
set things.
Yeah, exactly. But today we're looking at a condition where just the simple everyday act of scratching an itch can force your skin to build like a permanent biological suit of armor.
It's wild. It really forces us to confront how much of our physical reality, down to the microscopic layers of our cells, is actively shaped by our psychological responses to discomfort.
Because the skin isn't just a static wrapper.
No, not at all. It's highly responsive. And when it is subjected to chronic trauma, it fundamentally changes its own architecture just to survive.
Wow. Well, welcome to today's deep dive, everyone. We are stepping into the often murky waters of dermatology to solve a really fascinating medical mystery for you today.
And it is a tricky one.
Oh, totally. Our mission is to take a stack of clinical sources. We've got national dermatology guidelines, comprehensive histopathology textbooks, peer-reviewed research, and use them to distinguish between two intensely itchy chronic skin conditions.
Two conditions that honestly sound very similar.
Right. They sound similar, they often affect the exact same areas of the body, and they are routinely and dangerously confused with one another. So we are looking at lichen sclerosus, which we'll call LS, and lichen simplex chronicus, or LSC.
Yeah, and both conditions share the word lichen in the name, which
Mhm.
essentially means the skin has taken on a thickened, altered, almost moss-like appearance in certain stages.
Moss-like, yeah. And both are characterized by severe, debilitating itching.
Exactly.
Yeah.
But if you look past that shared symptom, their underlying origins, the way they present on the body, and their microscopic signatures are just fighting completely different battles.
Completely different. Okay, let's unpack this by starting with what a doctor actually sees on the surface. We'll look at the clinical picture of lichen sclerosus first.
Please start.
So, based on the national dermatology guidelines we're pulling from, LS most commonly sets up camp in the anogenital region. In women, this very often presents in a distinct figure of eight pattern that loops around the vulva and the anus.
Right. And the initial visible signs are highly specific once they fully mature. You see these flat, ivory, or porcelain white spots.
Like little white patches.
Yeah, exactly. And over time, those individual spots actually merge together to form much larger plaques. But, the color isn't even the most vital clue here. It is the texture. The structural integrity of the tissue just completely breaks down.
Yeah, the textbooks actually use the comparison of cigarette paper or cellophane for this.
Cellophane is a great way to picture it.
Right. The skin becomes so thin, so crinkled, and so profoundly fragile that the slightest touch can cause damage. We are talking about tissue that is effectively turning into wet tissue paper.
And because that barrier is so compromised, you see a cascade of secondary trauma. The capillaries just under the surface are no longer protected.
So they just burst.
Exactly, leading to severe bruising. Medically, we call it purpura or ecchymosis, and this happens just from normal daily movement or even wearing tight clothing.
Gosh, so any friction is just devastating.
Right, the skin cannot tolerate any friction, which inevitably leads to agonizing erosions and fissures.
And here is the truly devastating part of LS, I think. It causes irreversible scarring that actually erases normal anatomy.
Yeah, this is where it gets really serious.
The architecture of the body is slowly resorbed and lost. So this includes like the narrowing of the vaginal opening, the complete loss of the labia minora, or something called clitoral phimosis.
Which is incredibly painful.
Yeah, where the damaged skin scars over and physically fuses the clitoral hood. I mean, if this goes untreated, the anatomy doesn't just change, it literally disappears.
It really does. Now contrast that with lichen simplex chronicus, or LSC.
Right, the other one.
Right. LSC does not present as delicate cellophane. It presents as thick, leathery plaques. It is a tough hide.
Like literal leather.
Yeah. The normal hatch markings of your skin. If you look at the back of your hand right now and see those tiny crisscrossing lines.
Oh, yeah, the little geometric shapes.
Exactly. In LSC, those subtle lines become deep, prominent, and aggressively exaggerated.
The color profile shifts entirely too, right?
Oh, absolutely.
LSC can look angry and red, or it can become heavily pigmented. The sources say in darker skin tones especially, the area can become significantly darker or lighter than the surrounding skin.
Right, the pigmentation changes can be really stark.
And because LSC is fundamentally a disease driven by physical scratching, the area is almost always covered in scratch marks, and you'll find broken off hairs where the fingernails have just ravaged the surface.
But the defining clinical difference on the surface is that LSC, no matter how severe that leathery plaque becomes, it never causes a loss of normal anatomy.
It doesn't fuse things together.
Right, it does not fuse structures together, it does not resort to the labia, it builds up on top of the skin rather than, eroding the foundation.
Okay, so clinically, LS turns the skin into delicate, easily torn tissue paper that scars and erases anatomy, while LSC turns it into a thick, tough piece of leather.
That's the baseline, yes.
Wait, if one makes the skin thin and fragile and the other makes it thick and leathery, shouldn't a doctor be able to tell them apart instantly just by looking from across the room?
What's fascinating here is that diseases rarely accommodate us by staying in their neat little textbook descriptions.
Right, of course not.
In a late-stage textbook presentation, maybe you could tell them apart. But in the early stages of both of these conditions, before the cellophane thinning or the leathery hide has fully developed, they might both just look like a non-specific, swollen red rash.
Oh, interesting.
Yeah, or conversely, both might present as ambiguous white, scaly patches. So the naked eye alone often fails because the early inflammatory signs overlap so heavily.
Well, if the surface is giving us muddy waters, we have to look deeper. We really have to understand the mechanisms why these conditions happen in the first place to grasp what's tearing the skin down or building it up.
Exactly. It essentially comes down to a battle of inside out versus outside in.
Let's pull apart lichen sclerosus first. The research points to LS as an autoimmune and inflammatory condition.
Right. The patient's own immune system is basically misfiring.
Yeah, it's manufacturing autoantibodies, and those antibodies are hunting down a specific target called extracellular matrix protein 1, or ECM1.
Think of the skin as a brick wall. The cells are the bricks, and the collagen network in the deep layers is the mortar holding the entire structure together, giving it that elasticity and strength.
Okay, I can picture that.
ECM1 is a critical binding protein within that mortar. So when the autoimmune system targets and attacks ECM1, it is essentially dissolving the structural mortar of the skin.
So the collagen breaks down.
Right. It alters its form and loses its strength.
The wall just collapses upon itself.
The integrity is destroyed from within. And that is the inside-out disease process. The body is dismantling its own scaffolding.
Which is exactly why the skin above it becomes as thin and fragile as cigarette paper, and why the resulting healing process creates that dense, destructive scarring.
Precisely.
Here's where it gets really interesting, though, when we look at the outside-in mechanism of lichen simplex chronicus, which is sometimes called neurodermatitis.
Right, neurodermatitis.
Because this is entirely driven by a behavioral loop. The itch-scratch-itch cycle. It's a mechanical process. The chronic, repetitive rubbing and scratching of a localized patch of skin forces that tissue to adapt.
It is an aggressive defense mechanism. When you subject the epidermis to the constant trauma of fingernails, the skin cells basically realize they are under attack.
They panic.
Yeah, and to prevent the tissue from being completely scraped away, the skin kicks cellular production into overdrive, multiplying rapidly to build a thicker, harder barrier.
It's basically like a physical callus forming on a guitar player's fingertips.
That's a perfect analogy.
Right. When you first start pressing down on steel strings, your skin blisters and tears. But if you keep playing, the body adapts by thickening the skin on those fingertips into tough little pads so you can play without pain.
Exactly. The body protects itself.
Except in the case of LSC, the patient isn't trying to play a chord, they're trying to relieve a phantom itch.
And just like the guitar string alters the fingertip, the fingernails alter the epidermis.
Yeah.
But here's the cruel trap of LSC. As that skin thickens, a process we call lichenification, it actually traps and irritates the tiny nerve endings housed within the skin layers.
Oh, no, so it makes it worse.
Much worse.
Yeah.
Those irritated, inflamed nerves fire off even more intense itch signals to the brain, which of course forces the patient to scratch harder.
Which forces the skin to build an even thicker wall. Wow, the behavior itself becomes the engine of the disease.
It's a vicious cycle.
So if a doctor is looking at a patient and can't tell whether they are dealing with a collapsed autoimmune brick wall or an impenetrable behavioral callus, they have to take a tiny sample of the skin and send it to the lab.
Right, a biopsy is essential here.
We are going down to the cellular battlefield now to look at these two conditions under the microscope.
So a pathologist evaluating a biopsy for lichen sclerosus relies on specific chemical stains that color different cellular components, and they're generally looking for a classic red, white, and blue pattern.
Okay, let's decode those colors so we can visualize this for the listener. The red refers to the very top surface layer of dead skin cells. The microscope shows hyperkeratosis here, meaning those dead cells are piling up and thickening right at the top boundary.
Right, but just below that red boundary is the crucial white zone. This represents dermal sclerosis.
Okay, what does that look like?
Remember the mortar we talked about earlier?
Yeah.
Under the microscope, you can literally see that the healthy, robust collagen has been replaced by this dense, scarred, pale fibrous tissue.
Wow.
It looks wispy, the elastic fibers are completely gone, and it's heavily hyalinized, meaning it has this sort of glassy, abnormal appearance. This white zone is basically the graveyard of the autoimmune attack.
The graveyard. And below that graveyard is the blue zone, right?
Exactly.
This is a massive swarm of inflammatory immune cells, a band-like infiltrate sitting right at the base of the scar tissue, actively driving the ongoing destruction.
That's the blue zone. But the absolute deciding factor, the thing that really proves this is LS, is what is happening to the living skin layer sandwiched in between.
Right. So what does this all mean for that middle layer?
Well, pathologists look for profound epidermal atrophy. The living layers of the epidermis practically vanish. They thin out so dramatically that the fundamental anchors of the skin are lost.
The anchors.
Yeah, normally the bottom of the epidermis has these wave-like downward-pointing structures called reed ridges that interlock with the dermis to keep the skin attached.
Like Velcro.
Perfect, exactly like Velcro.
Right.
In LS, those wave-like ridges are completely flattened out. The skin has nothing holding it in place, which is why it tears so easily.
Okay, so the microscope shows LS has a dead layer piling up on top, a completely thinned out living factory in the middle, and a destroyed, scarred foundation at the bottom.
That's LS in a nutshell.
Now let's slide lichen simplex chronicus under the lens.
Okay, in LSC, the pathologist sees the exact opposite in that middle layer. They see acanthosis.
Acanthosis.
Yes, the living epidermis is undergoing massive, irregular thickening. The factory is in overdrive. So instead of those wave-like anchoring ridges flattening out, they actually elongate and plunge deep down, building thick structural columns to fortify the skin against the scratching.
And the deeper layers respond too, right? The constant physical trauma forces the deeper fibers to build microscopic vertical walls to defend the tissue beneath.
Absolutely.
At the very surface, LSC also features excess dead keratin piling up, similar to the red zone in LS, actually. But because the patient is constantly rubbing and pressing on it, that dead layer is packed down incredibly tight into a dense, compact shield.
If we connect this to the bigger picture, the foundational difference dividing these two under the microscope is the state of the living epidermis.
Just the thickness.
Right. The pathologist measures the thickness. If the living layer is experiencing atrophy, thinning out, and shutting down, it points to lichen sclerosus. If it is experiencing acanthosis, aggressively thickening and multiplying it, points to lichen simplex chronicus.
Which gives us a very clear binary set of rules. Thin means one thing, thick means another.
In theory.
But we know the human body doesn't respect our rules.
Never does.
Let's look at the plot twist in our sources, where these two conditions completely collide, coexist, or even perfectly mimic each other to throw the doctors off the scent.
It starts with a very logical chain of events, actually. Lichen sclerosus causes a maddening, intense itch.
Naturally.
The patient, understandably, scratches their LS continuously to find relief. Because they are subjecting that fragile skin to chronic mechanical trauma, they force the skin to start building that defensive callus.
Oh, wait.
Yeah, the patient develops lichen simplex chronicus superimposed directly on top of their lichen sclerosus.
They are happening in the exact same spot at the exact same time.
Exactly. So when the lab gets that biopsy, the slide is pure chaos.
I can't even imagine.
You literally have two diseases fighting for dominance on a single slide. The pathologist might see the dense, compact shield of dead cells and the thickened living epidermis from the constant scratching, layered right over the pale, scarred, collapsing dermal foundation caused by the autoimmune disease.
As if that pathological mashup isn't confusing enough, the textbooks reveal an even bigger curveball. Up to 1/3 of all lichen sclerosus cases might fall into a variant category known as non-sclerotic lichen sclerosus.
In SLS, yeah. The name highlights the missing puzzle piece.
The sclerosus.
Right. That defining white zone we discussed, the dermal sclerosis where the collagen is visibly destroyed and scarred, is entirely absent from the biopsy sample.
If the sclerosus is missing, the visual evidence just goes wild. Without that scarred collagen, non-sclerotic LS can actually present under the microscope with a severely thickened epidermis
Yes, the living layer multiplies.
and looking virtually identical to the acanthosis we see in LSE, or even mimicking psoriasis.
It looks exactly like it.
But wait, if a patient actually has an autoimmune disease that is actively destroying their anatomy, but their biopsy just shows a thick defensive skin layer with no white scarring, how is a doctor supposed to know it's not just the itch-scratch cycle?
Well, this is exactly why the lab can never operate in a vacuum. A pathologist staring at a glass slide is only seeing, a millimeter of tissue.
Just a tiny snapshot.
Right, a snapshot that might have been taken from an area where the sclerosis hasn't formed yet, or where the scratching has just completely masked it. When the pathology report simply describes a thickened epidermis with inflammation, the treating physician must combine that piece of paper with rigorous clinical correlation,
They have to look at the living patient.
because the physical damage tells the true story.
Exactly.
If the doctor observes any architectural loss, if the labia minora are actively resorbing, or the clitoral hood is beginning to fuse, that is the undeniable smoking gun.
That's the proof.
It is lichen sclerosus, regardless of what the tiny biopsy punch failed to capture. Lichen simplex chronicus, no matter how severe the scratching gets, it simply does not possess the biological mechanism to erase anatomy. The clinical observation and the microscopic evidence have to interrogate each other.
Which brings us to the ultimate stakes for you, the listener, in telling these two apart. Lichen simplex chronicus is a mechanical, outside-in thickening driven by behavioral trauma, while lichen sclerosus is a tissue-destroying, inside-out autoimmune collapse.
Right.
Getting the diagnosis wrong has devastating consequences because untreated LS doesn't just permanently erase genital structures. It carries a 4 to 6% risk of eventually mutating into squamous cell carcinoma, a highly dangerous form of skin cancer.
That's why treating them requires opposite philosophies. LS requires the use of ultra-potent topical corticosteroids like clobetasol to actively suppress the localized immune system, stop the autoantibodies from dissolving the tissue, and basically keep the disease in remission.
While treating LSC requires breaking the psychological and physical habit, you have to intercept the itch signal before the hand can respond.
This raises an important question, though. That intersection of the hand and the itch is really what stays with you. When you zoom out and look at lichen simplex chronicus, it challenges everything we assume about the boundary between our minds and our bodies.
Oh, totally.
In LSC, a totally invisible psychological state, a moment of anxiety, a period of stress, can manifest as a highly localized, physical, phantom itch.
Yeah.
And the simple reflexive act of scratching that itch sets off a biological chain reaction that literally reconstructs the histology of your body. It commands living cells to multiply. It forces the epidermis to build a leathery fortress, and in rare cases, that chronic repetitive friction can actually drive those cells to transform into squamous cell carcinoma.
Just from the mechanical trauma of your own fingernails. It really makes you wonder, how much of our physical reality is actively being shaped and altered by our psychological responses to discomfort. It turns out the skin isn't just a container holding us together.
No, it's alive.
It is a living, highly reactive canvas that documents the invisible battles of our immune system and the hidden anxieties of our minds. Something to keep in mind the next time you feel a sudden urge to scratch.